Thank you. So I'm going to present 4 different studies today. All of them have some practice-changing implications. We'll start off with the GEM Caesar study. Next. GEM Caesar, they asked a question about, can we do better than what we are doing today? Can we cure more people with stem cell transplant? We all realize there's a small number of patients who are potentially completely cured with autologous stem cell transplant, ranging anywhere from 10% to 15% when you look at old series. So here the question which was asked was one of the more effective regimens, KRD, followed by stem cell transplant, 2 cycles of KRD consolidation, and lenalidomide maintenance, which has already been proven in this setting. Can this be potentially curative for patients with high-risk myeloma? Next. So this was the patients with newly diagnosed high-risk smoldering multiple myeloma. Total of 6 cycles of carfilzomib, lenalidomide, dexamethasone, followed by high-dose melphalan, standard doses of 200 milligrams per meter squared, followed by stem cell rescue, followed by 2 cycles of consolidation, kyprolis, lenalidomide, dexamethasone, and then followed by maintenance, lenalidomide, dexamethasone. So they used the Mayo Clinic and the Spanish models in defining the high risk. And the primary endpoint they looked at was MRD negativity by flow cytometry after the high-dose treatment. And then the secondary endpoints included the response rates, time to progression, PFS, overall survival. Next. So these are the baseline characteristics. Small study, 90 patients. Overall, when you look at it, plasma cells, bone marrow infiltration ranged anywhere from 10 to 80%. High risk by Mayo Clinic model, 21%, Spanish model, 52%, and both of 27%. Ultra high risk is defined by serum free light chain ratio of more than 100, more than 1 focal lesion on MRI, and then PET positive without lytic lesions, small number of patients. The cytogenetic abnormalities, they looked at standard risk of 60% of the patients, high risk 34%, and unknown risk of about 6%. Next. And this is what they found, the primary endpoint of undetectable MRD rate. When you looked at the flow cytometry, 10 to the power of minus 5, 68% of the patients 3 months after transplant were undetectable. At 4 years, 43% of them still persisted to be in complete remission by MRD. And when you look at the MRD negativity with a higher sensitivity flow, 10 to the power of minus 6, 48% of them in remission after 3 months. And again, 48%, smaller number of patients on follow-up were still in remission at 4 years. Next. This the efficacy in the intention to treat population. Overall response rates, as predictable, was pretty high, 94% overall response rate with the induction treatment. Continued to be 91% after stem cell transplant, and after maintenance, very similar numbers. Median follow-up, we now have about 6 years. It ranges from 6 months to 88 months. 70 patients completed all the treatments, including 2 years maintenance. So about 80% of patients were able to continue the full regimen. Next. So this is the looking at the time to biochemical progression to multiple myeloma. 34 patients progressed biochemically, 9 patients during the treatment phase, and 8 patients during the first 4 years after treatment, and about half of them between the 4th and 5th year post-transplant. As I mentioned, the follow-up is only up to 6 years at this point, so our data is still limited as to what happens after 6 years. When you look at them, after a median of 14 cycles, 72% of them achieved a response when treated after progression. So all of them received daratumab, pomalidomide, and dexamethasone as rescue therapy. Next. So what are the factors which will predict biochemical progression? So these are kind of intuitive. The lines in blue are the MRD negative patients, and the line in red is MRD positive patients. So if MRD negative, the chances of staying in remission is 80% at 3 years. If you're MRD positive, it's only about 42% at 3 years. Next. This is the time to progression to multiple myeloma. As you can see, it's a prolonged curve there. Most of them are now hitting, like I said, 70-month follow-up. And the second curve is looking at time to progression by risk, truly high risk and ultra high risk. And you can see there's some mild difference. And again, it's the MRD negativity which predicts that patients will do well. As you can see, that blue line is almost flat on the top in the third curve. And if the MRD positivity, the risk of relapse does persist at 3 years is about 12%. Next. This is the overall survival, but clearly reflects that we have very effective second line, third line therapies also. So overall survival, when you look at it, only about 7 patients have died in this trial, 3 patients related to progression of disease, 1 with cardiac arrest not related to treatment, 1 massive ischemic stroke during treatment, 1 lung cancer, and 1 MDS. Next. So overall, in summary, what we're finding is that 68% of evaluable patients on this particular regimen were MRD negative at 3 months after the stem cell transplant, and 43% remained negative at 4 years post autologous stem cell transplant. 94% of patients had not progressed to active myeloma at 70 months. So this is based on the SLIM criteria and presence of MRD. And 48% had progressed biochemically, not active, but biochemically at 70 months. Rescue therapy was very effective with pomalidomide, darolutamide based regimens, 79% of patients having a response. And MRD negativity is obviously the biggest predictor as to who is going to do well. Next. So curative therapy with the KRD followed by stem cell transplant and KRD consolidation followed by LEN maintenance appears to be achievable to get these people into a cure in high risk smoldering multiple myeloma. Next. Next, we're going to go with the ASCENT trial. Next. So here the question was fixed duration therapy with daratumumab, carfilzomib, lenalidomide, and dexamethasone. Does it provide any benefit for high risk smoldering multiple myeloma? So a lot of studies on the smoldering aspect. So this is the study design, multi-label, again a phase 2 trial. Patients with untreated high-risk smoldering multiple myeloma, no evidence of amyloidosis. Again, very similar number of patients, 87 patients in this trial. Definition of the high risk is in the bottom part of the slide there. The treatment induction of about 24 weeks of induction with carfilzomib, lenalidomide, daratumumab, and dexamethasone, followed by another 24 weeks of consolidation. The difference there being the daratumumab went to every 4 weeks, and the dexamethasone dosing was lower at 20 milligrams weekly, making it more tolerable. And then went on to maintenance with just the lenalidomide and daratumumab for 48 weeks. So 1 year of induction and consolidation together, followed by about 1 year of maintenance. So a total of 2 years of treatment. Primary endpoint, complete response rates. Secondary endpoint of MRD negativity. Here the number is 10 to the power of -5, so not the highly sensitive flow that I showed you in the last trial. Overall survival, PFS, safety, and toxicities. Next. These are the baseline characteristics. Again, similar to what you'd expect in this patient population. Half were male, 84% Caucasians, high risk by FISH of about 20%, M spike of more than 2 grams of 72%, pre-light chain ratio more than 20, not 100 as defined in the other trial, of 31% of the patients. And the beta-2 microglobulin was kind of in the mid-range. Kidney function was fairly well preserved in the majority of patients. There were some stragglers with a creatinine of 1.9, elevated LDH in a small number of patients. So in this trial, the median number of cycles that was deliverable was about 23 cycles after a 26-month follow-up. So a lot of patients did tolerate the treatment fairly well, and only about 12 patients discontinued prior to completion of the 24 cycles. So this was a deliverable regimen to this subset of patients. Next. These are the response rates. As expected, it's very high. Overall response rate of 97%. 92% of them better than VGPR. Marrow MRD of 84%, 73 patients achieving that. And the median time to achieve that fairly brisk of about 6.6 months. When you look at the PFS, 3-year PFS rate of about 90%. 4 patients progressed, 3 of them with biochemical progression, and 1 of them developed plasma cell leukemia. Next. These are the safety, as you can expect, predictable side effects when you use this combination. We've all used this in the clinics before. Nothing striking here. So grade 3 and 4, as you can see on the right side, some colitis, diarrhea, pneumonia, syncope, hypertension, especially with the use of steroids. Next. So in summary, the combination of daratumumab, carfilzomib, lenalidomide, and dexamethasone given for a fixed duration of 2 years in patients with high-risk smoldering multiple myeloma was associated with a high response rate, including very high rates of MRD negativity. So hard to compare the two trials. This one has a shorter follow-up. We'll need some longer-term data to see how this pans out. And is there any shoulder on the right side of the curve if people continue to stay in remission? Next. Next. And the next trial I'm going to share is the IFM 2017-03. Next. So this is a very relevant question for our elderly patients and patients with poor performance status, patients with brittle diabetes. Can we really cut down the dose of steroids and use daratumumab instead or some other agent instead? And will these patients do well if we do not use steroids? This is something that we face in the clinic every day, regardless of which regimen you use. Next. So quite clearly across the years, we've gone down on the dose of steroids. We started off with extremely high dose steroids. Now we've gone down to the 40 milligrams weekly. We're now stepped down even further to 20 milligrams weekly on some patients without compromising the efficacy much. So in this trial, the question which was being asked was, can we let go of the steroids completely? Because a lot of the long-term side effects in these patients tend to be from steroids, osteoporosis, diabetes, hypertension, all of that. So what they did, patients aged more than 65, newly diagnosed, a frailty score of more than 2. It kind of translates closely to, ECOG, a little higher than that. Primary endpoint in this trial was PFS. There are other things they looked at: overall response rate, very good partial response rates. And the randomization was 2-1. The upper arm, experimental arm, daratumumab, standard doses, along with lenalidomide, full doses, 25 milligrams, as compared to RD, which is lenalidomide with dexamethasone. And treatment was continued till progression of disease or unacceptable toxicity. Next. So this is the randomization, fairly well randomized on both sides. Nothing stands out between the two arms. It seems like a fair randomization. Next. Oh, actually, can you go back one slide, please? Sorry. So the one thing I would like to point out is the disease stage on the right side. As you can see on the top, about 50% of the patients had stage 2 disease and 32% of the patients had stage 3 disease. So there were some higher risk patients in this trial. And we look at the deletion 17, when you look at the cytogenetics, again, 17% of patients on the first arm had high risk as compared to 22% on the second, on the regular standard arm. Next. These are the response rates. Daratumumab with Revlimid, response rates of 96%. Revlimid dexamethasone, response rates of 85%. Across the board, daratumumab performed much better than the dexamethasone combination. This was statistically significant, p-value of 0.001. When you look at the MRD, again, 10 patients with the daratumumab arm as compared to 3 patients on the dexamethasone arm, again, statistically significant. Rate of response over time, as you can see with daratumumab, again, fairly brisk response and a faster response than what you saw with the steroids. Next. These are the safety data. Again, the randomization is 2-1, so don't look at the numbers. It's probably better to compare the percentages here. So myelosuppression was definitely higher in the daratumumab arm, as you can expect. The risk of infections were fairly well balanced on both of them. Chance of treatment discontinuation was similar in both the arms. Next. So overall, what we learned from this trial is combining daratumumab with lenalidomide without dexamethasone demonstrated a very significantly superior overall response rate. Again, this is a very compromised population, age more than 65, frail patients. Even in this, we saw some surprisingly high response rates. Rates of VGPR was better. Rate of MRD negativity was better. Safety profile was fairly similar, except for the myelosuppression, as I mentioned. PFS analysis is ongoing. Hopefully, we'll see that either at the ASCO or maybe at the next ASH. Next. So this definitely is one thing which you could consider for your frail elderly patients, especially those brittle diabetics patients who cannot tolerate the steroids at all due to neuropsychiatric consequences or medical, such as hypertension and diabetes. And dexamethasone can be safely omitted from treatment in this patient population. Next. The last study I'm going to present is the Majestic-2 study. Next. So on October 25th, so about 4 months ago, we got FDA approval for teclistamab, brand name of Tecvayli. It was the first bispecific B-cell maturation antigen, a BCMA-directed CD3 T-cell engager for patients with multiple myeloma who had received at least 4 lines of prior therapy. So they needed to have been on a proteasome inhibitor, immunomodulatory agent, and an anti-CD38 monoclonal antibody. What we have seen with this, as a single agent, response rates of 63%. Remember, this is a very highly pre-treated population. All of them have had several lines of therapy. Median follow-up of 14 months and median treatment duration of about 8 months. MRD negativity was achieved in about, of all the patients, about 26% of patients. Next. So then the question which was asked in the second trial, the Majestic-2 trial, does the bispecific antibody teclistamab in combination with daratumumab and lenalidomide provide benefit for patients with multiple myeloma? Next. So this is something which is the phase 1b trial, but we wanted to present this because of the strikingly positive data which we saw in this trial. So patients with measurable multiple myeloma, at least 1 to 3 prior lines of therapy. So teclistamab was used in a step-up dosing, mainly to prevent CRS. So 0.7 milligrams per kilo or 1.5 milligrams per kilo given weekly. And then if they tolerated it well, was transitioned to 3 milligrams per kilo every 2 weeks, starting at cycle 3. So this is a common thing that most of these agents, bispecific antibodies, are using to reduce the risk of CRS, especially when you're considering giving it in your offices. That's very critical because there's a steep learning curve in management of CRS. Daratumumab given at fairly standard doses, lenalidomide given at standard doses, dexamethasone was also given 40 milligrams once weekly. Primary endpoint, this was a safety and dose-limiting toxicity study. Key secondary endpoints, overall response rate, VGPR, and more than CR. Next. These are the baseline characteristics. Again, very small number of patients, so I don't want to dwell too much on this. The one thing I would like to point out is the high-risk cytogenetics. As you can see, a significant number of patients had high-risk cytogenetics. And then the refractory status, when you see it on the right side, refractory to lenalidomide of 46% or 15%, depending on which group you look at. Refractory to an anti-CD38 monoclonal antibody of about 20%. And median prior lines of treatment of about 2. So most of these patients were in the 3rd line of treatment. Next. This was the safety data. So the first thing which is very important to all of us is obviously the risk of CRS. So CRS in this trial, there were no grade 3 and 4 CRS. All the CRS, as you can see on the right side, was grade 1 or grade 2. So about 21 patients had a grade 1 CRS and grade 2 of about 5 patients. The rest of the side effects are all predictable with this combination related to the combination of these drugs. There was some fatigue. There was COVID-19, obviously. It was done in that era. Insomnia, mild hypophosphatemia, myelosuppression, as you can expect. Overall, the biggest side effect was neutropenia. 25 patients had it, or 78% of the patients. So that was really the dose-limiting toxicity here. There was also some increased risk of infections and thrombocytopenia. Next. So what are the response rates? Now, as I mentioned before, average number of previous lines of therapy was 2. And what we saw in these patients was overall response rates of 93%. Granted, this is a very small study of 26 patients, but that's a fairly striking number when you're treating patients in the 2nd and 3rd line of treatment. Median follow-up we have is about 8 months, time to CR of about 3 months. And these are the responses on the right side. As you can see, responses were observed in patients who are refractory to daratumumab and or lenalidomide. So quite intriguing drug and certainly something we need to keep our eyes open for. As we open our clinic doors to bispecific antibodies, I'm sure all of us are going to get better. And certainly there's a learning curve because most of us have not been used to it in the past. Next. So the combination has potential with the 80% response rates, remaining 80% of patients remaining progression-free and on treatment at data cutoff. And the safety profile was consistent with all the individual components. The good thing was the grade 3 and 4 CRS or neurological events was not seen. So now we have the Majestic 7 trial. It's open label phase 3 study, which is going to compare these two regimens. Next. So certainly this is something which we're going to keep our eyes open to, and more data to come once we get the Majestic 7.